This episode is brought to you by Marqeta. When it comes to your payments provider, you can't afford to compromise. Marqeta's modern payment solutions flex with your business without the trade-offs. Stable and agile, secure and innovative, scalable and configurable. If they say you can't have it all, don't believe them. Your business demands more. Choose a payments provider that delivers more. Choose Marqeta. Visit marqeta.com/Spotify to learn more.
Icy Hot Pro with 2 max strength pain relievers. Targets multiple pain receptors. Ice works fast, heat makes it last.
This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This podcast offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we are going to be discussing an updated meta-analysis on the benefits of behavioral treatments when added to buprenorphine for opioid use disorder. How are you doing, John?
I'm doing great. How about you today?
Doing fine. I don't think this episode will air for a while, but it's almost Halloween. We're just carving pumpkins before I started recording in our house. Are your kids excited for Halloween?
Yeah, I feel like every year we get more and more pumpkins. I think I have like 18 pumpkins here, and I bought none of them. I don't know where they keep coming. And I take care of a bunch of farmers, keep dropping off pumpkins at my office. So I've got like 5 of them on my desk. Yeah. And I also have like all these canned vegetables that like a bunch of my farmers drop off. And I feel like it looks like I'm stockpiling for some sort of like apocalyptic future.
If you have to barricade in your office?
I'd be good. In my office, I think I would last the longest out of the dogs. Well, at least with my supplies.
Your supply of home canned vegetables?
Yeah, exactly.
That's awesome.
Yeah.
So, John, is there anything you want to share with our audience in addiction medicine news this week?
Yeah, I thought this was a relatively brief article that was kind of summarizing like contemporary themes of addiction medicine. It's from Stat News, and the title is Head of Addiction Medicine Society Warns of Treatment Cuts and Rising Threat of Gambling. And this is in response to Dr. Stephen Taylor, that's president of American Society of Addiction Medicine. They spoke at Stat Summit in Boston just in October 16th of 2025. And a couple of the highlights of the talk. One is lots of criticism about Trump administration policies regarding cuts to Medicaid, shutting down SAMHSA, how this has been like catastrophic for us and that, lives will most likely be lost without this funding and without these services. Also kind of heavy warning against this kind of policy trend or this discussion about possible involuntary civil commitment for substance use disorder. And really, it kind of just highlights kind of a growing disparity in terms of how people are viewing substance use disorder. And it seems like it's almost kind of being criminalized. And one thing I thought was interesting is 88% of the currently 48.4 million Americans with substance use disorder currently receive no treatment. So like lots of opportunity for improvement. Also, drinking a little bit of the haterade for RFK Jr., claiming that 12-step programs are the gold standard and kind of poo-pooing medication for opioid use disorder like methadone and buprenorphine, which is interesting because as an addict in recovery, this is a theme I think we see sometimes, kind of like people that recover one way, kind of hating on how people recover another way. Kind of some interesting areas of agreement that, there probably is some role for naloxone and maybe some limited role for medications for opioid use disorder per the current administration. And then also interestingly kind of surprised about kind of emerging issues with gambling kind of on the rise, especially kind of gambling associated addictions and how online sports betting really increases risk of public health and suicidality. So kind of interesting there. And of course, we couldn't get through any discussion of medicine without talking about optimism for GLP-1s.
Yeah. But I think the current administration doesn't like GLP-1s, right?
Not for weight loss.
Right. I mean, they're very much on like your problem is because you're weak, and it's sort of an individual responsibility to cure your own problems on your own. without medication.
Yeah, so I think it's interesting. I mean, we'll see how some of these policies trend in the future, but I think certainly interesting. I think highlighting gambling is interesting. I think it's an addiction that we often kind of don't give as much screen time and probably we don't talk enough about. But I have lots of patients that they can really ruin their life in a weekend of gambling, right? It's really kind of
Yeah.
tough.
Well, I think we've talked about this a little bit before. The advent of sports betting, but having it on your phone, so it's with you all the time, you can't avoid it, and the ability to place a million kind of just-in-time micro bets right as the game is going on, so there's no delay and you're winning or losing. It's like the fentanyl of gambling, this sort of in-your-pocket sports betting. The dopamine hit is immediate and huge, and then there's a drop, there's no delay. It's just very compelling for people, and it's spreading, and I don't think it does anybody any good.
Yeah, I have a younger brother, loved him to death, and I remember I was out to dinner with him a couple of years ago, and like while we were out to dinner and drinks, he was gambling on women's MMA and women's bowling finals on his phone, and I was like, you got a problem if you're gambling on women's bowling results. I mean, that's not even like something fun to watch, right? I shouldn't say that,
Right.
but that wouldn't be what I would think of as primetime gambling.
And did he agree with you
I think
that he has a
I think he
problem?
won like $20, so I think it didn't work at the time.
Oh my god, right, it's just reinforcing enough to keep you coming back.
Yeah, yeah, exactly. How about you? Any kind of interesting articles?
Yeah, there was a really interesting article I read about adolescent brain structure. It's not really a news article, it's a scientific article, but it wasn't the kind of thing we would, um, cover in detail on the podcast because it's not really actionable. It doesn't, like, help change your practice. It's more of a basic science article, but it gets to the question of addiction being something genetic versus just a problem of willpower and behavior. So there's just really still a lot of debate in our country about the nature of addiction as a disease, and the role that genetics versus environment play in determining who will develop an addiction. And so this was a study published in JAMA Network Open, and they used data from the ABCD study. If you're a family medicine or peds, you probably know about that. It's called the Adolescent Brain and Cognitive Development Study. And they looked at these neuroanatomical variants associated with early adolescent substance use and whether or not those variants were present prior to the initiation of use or only appeared after. So it's known that after substance use, there are anatomical changes in the brain. And the theory has always been that the substance use causes those changes, and then those changes further more substance use. But this is a huge cohort, over 10,000 people, and they had structural brain imaging prior to the initiation of substance use. And they found that in adolescents who started using substances of some kind prior to age 15, there were these neuroanatomical differences preceded the initiation of drug use. They had greater whole brain cortical and subcortical volumes, but thinner prefrontal cortex and thicker cortex in other areas. And that thinning of that prefrontal cortex is seen in substance use disorder. We thought it was a consequence of the neurotoxic effects of substances, but perhaps these are changes that are genetically present at birth that predispose you to substance use. It gives more weight to the idea that substance use disorder has a strong genetic component rather than being a problem of morals or willpower. So, John, would that finding surprise you?
No. I mean, does
Okay.
it surprise you?
It doesn't surprise me. It might have surprised some people though, because there were some theories about like how these changes from substance use, like the changes that they thought were caused by substance use, lead to some of the behaviors related to substance use. And this kind of turns that on its head. It turns out these changes aren't necessarily caused by substance use. There's something that was there at birth or there congenitally. So I mean, there's a lot to know, but I think it's very interesting. I mean, anyone who's worked with a lot of people with addiction can't deny the genetic component. I mean, there's also a strong environmental component, but I've worked with enough people who like didn't have any environmental risk factors and yet fell into addiction super quickly on a brief exposure to substances, and they had a strong genetic risk.
Yeah. I mean, I, I think for anyone like in the scientific community, right? I think it's undeniable there's strong, at least a stacking of the deck against you, right? And I can think about like how many patients you hear like in your clinic with a substance use disorder, and they'll talk about like they remember the first time that, they had like oxycodone for a medical procedure, and they'll like vividly describe it and discuss like how like the feeling and the euphoria and how it was the best thing ever. I remember like I've only had oxycodone like one time when a dog bit me a bunch of times, and I hated it. I felt like gross, and like I was like nauseous and like didn't feel well on it. And like I think I took two of them and I was like, screw that, I'm gonna do ibuprofen. And so it's funny how like such a paradoxical experience to how people describe like initiation, right?
Right. Well, and it's not across the board. I do know some people who became addicted to opioids and their initial experience was negative rather than positive. But you're right. It's just obvious how different people respond, positively or negatively to that initial exposure. So I thought this was super interesting. I'll put the link in the show notes.
Yeah, I think the more we kind of give scientific validity to it and less of this kind of moral failing nonsense is, I think, better, right? More and more evidence.
Well, that's the thing. It's like, especially with fentanyl and the newer, synthetic drugs out there, moral willpower is just not strong enough to fight against them. You know, you can't think your way out of it. And it's like, there's no consequence that's too great to discourage people from using. It's beyond logic, it's beyond willpower. And why does this happen to some people and not others,
Yeah.
Um,
Well, thanks for that.
yeah, it's really interesting. So, John, you ready to tell us about this article?
Yeah, so this is kind of an interesting article. I'm sure we'll have some discussion. It's called Behavioral Therapy as an Adjunct to Buprenorphine Treatment for Opioid Use Disorder, and it's from JAMA Network Open from August of 2025. So a little bit of background, like buprenorphine combined with low-intensity psychosocial support is highly effective for treating opioid use disorder. Medical management has been shown to produce higher rates of abstinence and reduce opioid use. And so when they refer to medical management, they're kind of talking not just about medication, but kind of office-based, kind of short, brief encounters with a clinician. Many individuals do not fully respond to buprenorphine or medical management alone. So the thought is adding high-intensity behavioral therapies. The most common one we all know about is cognitive behavioral therapy, but also things like mindfulness, relapse prevention, has improved outcomes with other substances for treatment such as methadone or naltrexone. So they're kind of have been useful adjuncts. Large studies on buprenorphine have shown mixed results, that there's limited benefits from behavioral therapy beyond medication management. And there's like a lot of dichotomy in how those studies are reported. So it's kind of an area of question mark. The impact of these behavioral health therapy on treatment retention and overall functioning really remains understudied, and we really don't understand the relationship. So many people kind of postulate that certain subgroups, such as people with like PTSD or anxiety or concordant behavioral health disorders, may benefit more from combined therapy than just medication, medical management alone. But we don't really quite still understand, besides our clinical gestalt, who that's referring to. So, kind of personalized treatments are currently kind of recommended to talk about who would benefit from these enhanced behavioral supports, but we don't quite know, like, from a scientific evidence-based perspective, who should we be counseling should really consider incorporating that. So the clinical question of this study is, one, does adding behavioral therapy to buprenorphine and medical management improve treatment retention in people with opioid use disorder? Two, does adding behavioral therapy improve functional outcomes? So that was kind of across medical, psychiatric, social, legal domains in individuals receiving buprenorphine with medical management. And three, do certain subgroups like PTSD, heroin use, history of pain, depression, benefit from the additional behavioral therapy more so than other subgroups? So is there like a magic subgroup that we should be targeting with these? What's your thought on those questions, Sonya?
I mean, they're great questions. Many people in recovery use behavioral treatments. Many, many people find them helpful. But I think the assumption that they are better than medication or somehow required for a full recovery, that's the big question that needs to be reexamined. And I think you said earlier in the recording, just because something works for someone doesn't mean it's going to work for everybody. And saying that adding behavioral therapy doesn't, compared to placebo, doesn't improve outcomes, doesn't mean it didn't work for some people. People start to feel like you're invalidating their experiences. If you say behavioral therapy doesn't help in general, you're saying it didn't help them, which is not true. It just means you can't recommend it in general. And that's a subtle point that I think a lot of people in recovery using behavioral treatments don't quite get. They feel like you're criticizing their recovery if you say that it can't be recommended generally.
It is interesting. In like economics, they talk about the profile of American healthcare consumers, like as a customer. And they really kind of refer to this term of rugged individualism, where kind of like people really value choices over outcomes. And so I guess, exactly what you're saying, kind of forced treatment, is that beneficial? I think the almost forced anything in healthcare is not kind of the consumer profile that we're seeing, especially not anymore. So a little about the study kind of methods. So it's a study designed to secondary analysis of 4 RCTs from 2000 to 2011 involving 869 adults with a DSM-4 diagnosis of opioid dependence across 13 U.S. sites, comparing buprenorphine and medical management with or without additional behavioral health therapies. And this varied from the 4 subgroups, but it was mostly cognitive behavioral therapy. There was some contingency management and counseling. And it was looking specifically at buprenorphine retention, opioid use, and function across multiple life domains. To give you an idea of the 4 studies that were included, the first one was Phelan et al. From 2006. It was a 24-week RCT comparing once versus thrice weekly medical management visits or enhanced medical management visits of 166 adults with opioid use disorder with up to 24 milligrams of buprenorphine. So that's a lot of touch points for a non-behavioral health intervention, right? So 3 per week, that's a lot. The second one was Phelan et al. From 2013. It was an RCT of 141 adults comparing physician management alone versus physician management plus cognitive behavioral therapy with weekly buprenorphine. Third was Ling et al. From 2013. It was a 16-week trial of 202 participants randomized to cognitive behavioral therapy, contingency management, both or no behavioral therapy with buprenorphine. And third was Weiss et al. From 2011, which was a multi-site RCT of 360 adults in extended buprenorphine treatment, randomized to standard medical management versus medical management plus counseling. So those were the different trials.
It's a little unfortunate that none is kind of newer. Like in covering sort of this time in the era of fentanyl.
Yeah. I feel like I thought that I was about to say they are that old, but then I'm thinking I was in college during some of these. So yeah, it's old.
I mean, it's not that old, but
It's old.
It could be newer.
Yeah. In terms of primary outcomes, they look at opioid use, weekly measurements over a 12-week, and that consisted of like timeline follow back method. And they did have an objective measure of urine drug screen results as well. In terms of buprenorphine retention, they looked at number of weeks of buprenorphine was received during the 12-week treatment period. And then for functioning, they did the Addiction Severity Index, which has 7 domains of assessment, including medical, employment / financial, social / family, alcohol, drug, legal, and psychiatric. So that was kind of your functional domains. In terms of key moderators, they looked at to see whether or not there was kind of like a subgroup that kind of benefited the most or kind of was unlikely to benefit. They looked at things like age, sex. They did pain as assessed by a short form 36, so FF36 survey. They looked at history of kind of heroin use, so versus prescription opioid use. So that was kind of the big comparison here, not fentanyl era. So this is kind of heroin versus prescription opioids. Cocaine use was its own kind of variable there, so it's binary in terms of how it was coded. Previous treatment episodes, do people with kind of like sequential, not optimal responses benefit from the addition in like their 3rd, 4th, 5th round of treatment? So is it kind of useful for people that don't initially respond? Depressive symptoms, so looking at the Beck, which was 2 studies. And then they also had the Center for Epidemiological Studies, Depression Scale, and another 2 studies. So they had 2 different measures of depression, but depression was included in all 4. And they did kind of PTSD diagnosis. And so that was only available from half of the studies, so not all of them. They did this kind of harmonizing data analysis where they tried to kind of compare kind of key data points from the 4 different studies together to make it so that they was able to have like a meta-analysis, because it's not exactly the same, right? So they had to statistically adjudicate that.
Right. Well, and they looked at studies that were kind of more randomized controlled trials as opposed to more observational studies.
Yeah.
Which is good.
What do you think of that trial and how it was designed? Like what thoughts you have?
Yeah, I mean, I think it's good. I like the subgroup of people with PTSD, thinking they might benefit more from additional supports. Of course, I like that they looked at all meta-analyses. I mean, that's the problem with behavioral interventions, especially like these prospective cohort studies. like people who benefit from behavioral treatment stay in behavioral treatment. It's like the old adage, if you go to 500 AA meetings, your chances of being alcohol free are very high. But like, who goes to 500 AA meetings? Only people that it works for. So that's the problem with all of these prospective cohort studies on behavioral treatment. So I really do think that this, having randomized controlled trials and a meta-analysis of those you know, is great. I'll look forward to hearing the conclusion.
Yeah, so kind of is this trial valid? Let me kind of point out some points to think of before we talk about the results. The manuscript was funded from NIDA, so no industry bias. There was some kind of minor industry fees from Al Kermes and Eli Lilly, and then also an honorarium from Addiction Society, American Society of Addiction Medicine. But I doubt there really wasn't kind of a direct pharmacy tie here, so I don't think that made any difference whatsoever. It's a large RCT, so 869 is a pretty good size addiction medicine trial. Now, like I said, it was kind of like meta-analysis together of these, or kind of combined data analysis. So not its own trial per se, but kind of a large amount of subjects were pooled into this for analysis. The data was a combination of self-reported and objective measures, which is nice. So I always like it when we have some sort of objective finding as well for substance use disorder evaluation. I like the inclusion of the addiction severity index as an outcome, because I think that this is the big complaint that we're seeing over and over again when people are critiquing articles, is that we're not looking at functional outcomes. We're looking at kind of these binary weeks in treatment, UDS results, but not kind of global function. So I love the fact that they captured that and they realized that was an important outcome to report. The data was 4 trials were analyzed with this harmonization protocol, and like I said, they did there's a very extensive statistical analysis section for this. That even having done stats now many times, and just recently done stats again in grad school, it was somewhat part of it was over my head. But even with your best analysis, right, there still is some apples to oranges. There's always kind of a unknown confounding between these that I think you're going to have. So they did a good job trying their best to do it, but it's not the same as if it was all from a single primary study. I do think that a valid point, as I talked about before, is that medical management in these studies, at least some of these studies, it was very labor intensive, and I don't think it reflects in vivo medical management. I think many people come to their buprenorphine prescriber, they pee in their cup and they get their script and they leave. And they'll often tell me when they come to see me as like new patients or from other clinics that the visits are like 2 minutes at their old doc. This was kind of pairing like a longer visit, sometimes up to 3 times per week. And at those visits, there was kind of like, it was more intense provider feedback regarding how they're doing. So I think this is more of a ideal conditions for an office without behavioral health intervention, not real world, if that sounds fair.
Well, yeah, and I wonder if, again, not to harp on the age of the trials, but these are like 2006, 2013, 2011. Like in those eras, it was much less common to do outpatient buprenorphine. And I remember like you were supposed to do in-office inductions. The patients were supposed to stay in your office for their first dose. It just like the treatment standards were much more intensive. Then now it's like any other prescription. Here's 12 weeks worth.
Wasn't that silly when we did that? Yeah.
So, full disclosure, I never ever did an in-office induction. I
was going to, and then you told me we don't do that. So
I was like, I don't know.
Before it was a thing, you were telling me not to do it. So you get the OG there.
Sorry if I corrupted you. I apologize.
Only cognitive behavioral therapy and counseling were tested. So this kind of limits generalizability. There's other options. I think I always tell the medical students and the residents that like, if you see the term cognitive behavioral therapy, grab it as long as it's not bipolar, but otherwise it tends to kind of be the answer for everything. There's so many other things now. I know there's an emergence of kind of like relapse prevention, mindfulness based therapy as well. So I think that there's and certainly contingency management. I'm sorry, there was some contingency management, but those are kind of like big mainstays of behavioral health therapy that's very effective now. And I think that just in the era of these studies, that wasn't kind of an emerging trend yet. I think 12 weeks is a decent size. I think it might be too short. We know that in other diseases like anxiety, depression, that counseling can be as effective as medication, although counseling effects are delayed, right? So we know that people respond quicker to SSRIs than counseling, but they both will get you to the same place in the long run. So it might have been too short to see an effect. Like I said, there was low rates of psychiatric conditions like PTSD. So if you had a low N of those conditions, it might be hard to find power in that, which is this is the only time I'm ever going to say this. There wasn't enough mental illness. It's like
Yeah.
something I've never said any day
Right.
of my life, right? So all trials were conducted in the pre-fentanyl era as well. So I think, we know that the drug supply has evolved and kind of our treatment needs have evolved as well.
Well, and I guess the only thing I would add, like you said, it's 12 weeks is a little short. It's not too short to see if the medicine really kind of helps you stop your substance use. But if you're looking at these functional outcomes, like did you get your driver's license back? Did you go back to work? Did you get housing? Like that takes a long time. So 12 weeks is a little short for those like big life outcomes.
Yeah. So what were the results? Demographics, 869 participants, 582 were male. So that's about 67%. Mean age was 34. Most were white, 82%. Mean age of education or mean education years was 12.8 years. And a little less than half, 48.9%, were full-time employed. In terms of the primary outcomes, so opioid use, illicit opioid use, there was no significant difference between groups with versus without additional behavioral therapy. So when you look at kind of weeks opioid free with therapy was 7.16 versus without 7.0, and they did a beta coefficient of 0.28, which was not statistically significant. In terms of buprenorphine retention, there was no significant differences between groups with versus without additional behavioral therapy. Kind of mean weeks of buprenorphine with therapy was 10.29 versus 10.21, beta coefficient of 0.00 with a P of 0.98, so also not statistically significant. In terms of functioning with this addiction severity index, there was no significant difference in outcomes between participants who received additional behavioral therapy and those who did not. And interestingly, there was kind of really no domain that came out to be statistically significant. Although when you look at kind of the follow-up, there were slight decreases in drug domain, family social domain, employment domain, legal domain. So not statistically significant, but there was kind of select domains that had a trend towards possible improvement. So kind of summarized in terms of the primary outcomes, illicit opioid use, retention to treatment, and functioning, there was no statistically significant difference over this 12-week period with or without behavioral health incorporation. In terms of looking at the moderator, so let's find that subgroup that makes a difference. So there's got to be someone that benefits from it. Interestingly, when you look through it at all, age had no effect on retention or moderation with behavioral health. Gender had no effect on moderation. Heroin use had no effect on moderation. Interestingly, cocaine use had a very slight effect on retention with beta coefficient of negative 1.04, and that was statistically significant. So P of 0.04. Prior treatment had no effect. So big surprise there, right? I would have thought that the third, fourth treatment patient would have been the one that benefited here, but that was not the case. Pain, interestingly, had a marginal effect on retention as well. So then that was statistically significant. The beta coefficient 0.17 and a P of 0.049. And PTSD kind of moderated opioid use, but it was not significant after correction with multiple regression. And no effect with depression, which is surprising because depression, counseling and behavioral health helps depression. You would think in that group they would at least benefit just from the depression. So really the only kind of moderators that came out here was slight associations with cocaine and pain. Kind of not what I was expecting.
So if you cast your mind over your own patients, and this is just sort of your gestalt, who benefits from addition of behavioral therapy, recovery support services, that kind of stuff? Who seeks them out? Who uses those services?
Who seeks them out or who benefits?
I guess it's hard if you assume that the people who seek them out are the ones who are benefiting.
I actually don't know if that's the case, if I'm being honest, just anecdotally. I feel like a lot of my people that are doing well, probably with or without my help, I feel like they really kind of buy in and they love my recovery support person. I feel like they touch base all the time, and I don't really have concern about them as much. I think the people that benefit the best is not really any of these groups. I feel like it's the people with kind of chaos in their life. It's not really like a DSM diagnosis or a concurrent substance use disorder. It's just kind of life chaos, and kind of that organization can be beneficial.
Hmm.
What do you think?
Well, I don't know. My patients who are doing absolutely the best, who are the most functional, don't use recovery support mostly. Um, but whether that's just because they don't need it or they like whether it would have benefited them or not, I don't know. But my patients who, hold professional jobs, have no chaos in their lives, no legal issues, their lives are very stable. They don't tend to utilize recovery support. I see the sicker people using recovery support more because they need more help. So they'll turn to that resource. But like you said, it's often for life help, not so much actual therapy and
But
counseling.
but the chaos that the disease creates in your life is part of the treatment, right? I feel like you have to kind of. I mean, it's just it's too chaotic to navigate treatment. So I think it's. I mean, that is part of it, right?
Yeah, yes and no. I mean, I have some people who get into treatment before the chaos really hits, you know? They
Really
realize it's coming. Yeah, like I have some people who haven't trashed their lives. They just are using drugs and can't stop. And like the worst that's happened is they've like spent a lot of money.
interesting. I feel like I hear that, and then I feel like the longer I get to know those patients and query them, it comes out that there has been some consequences that maybe they didn't feel comfortable telling me earlier on.
Yeah. Well, there's always some consequences, but
Yeah,
not the big ones. Loss of freedom, loss of health, that kind of
yeah.
thing.
So I think it, I feel this is an interesting article. At the same token, I feel like I'm not. I feel like we've just been bashing on behavioral health. I think they have an important role here, right? So I think it's the question from the data really becomes: we still don't. Like, am I going to offer behavioral health services to my patients? Yeah, I think I want to still do what I'd currently do, which is I'm going to talk about an individualized recovery plan that may or may not involve behavioral health involvement, depending upon what's going on. I do have kind of a bias where if you have a lot of mental health conditions that would benefit from behavioral health involvement, probably going to recommend that more so for just kind of like general wellness, not necessarily mandate it, but certainly something I think that would be very beneficial. I don't think, and my practice has changed over the past like 7 or 8 years, where like I don't mandate treatment anymore. I really, for the most part, like I let people decide what they think would be beneficial. The only people that are enforced treatment are currently court mandated, and like my role isn't to be the police officer. My role isn't to be like an enforcer. Right? I'm here to help them. So if they think it works for them, great. I'll support them with it. If it doesn't, that's fine as long as they're doing well. If they're struggling, I might recommend it, but I'm certainly not making them do it. So I think that this article kind of adds to the debate. I think there's still a role. I just don't think we have identified the group that benefits the most reliably.
Well, right. It's something that a lot of people like and benefit from, but we can't claim that overall it's beneficial for opioid use disorder and that everybody should do it. And so it's very relevant back to our sort of current administration who really think that behavioral treatment is the way to go. Like, we can't say that it really actually is better. It doesn't mean it doesn't help some people, but people have got to be able to choose it if they feel it would help them and not have it be mandated and not have it be the focus of our treatment.
Yeah, the only argument I'd have from kind of extrapolating that from this particular study is I think, like as I said, I think 12 weeks is still too short to truly make that decision. And then the other thing is, I think it's hard because often when we're comparing behavioral health involvement versus medical only involvement, I think there's a bias here because when we're studying it like this particular one, there is a fair amount of behavioral support being given by the prescriber, right? And I don't think that that is real world. I would like to see a real world study where truly you have someone coming in for medical management, maybe like just medication management alone versus medication management and motivational interviewing versus like medication management with behavioral health. And I would like to see those three groups compared because I think that there is a difference. And I think a lot of people are unfortunately just receiving medication at their visits. And maybe I'm wrong, but that's just what I hear from a lot of patients that establish with me.
Yeah, I hear that as well, but I guess the question is what are the outcomes you're looking for and what do people really need, you know?
Yeah. Yeah.
Well, thank you. Very interesting and a good update to this question that's been a bit of a perennial debate ever since buprenorphine kind of came on the market. So, John, we did get some talk back. We got an email from a listener, Dr. Eileen Barrett, and she happens to also be the president of the American Medical Women's Association. She had a comment about episode 65 regarding varenicline and bupropion for alcohol use disorder. Dr. Barrett wrote, I thought it was interesting when I went to the paper on varenicline plus bupropion and the authors didn't mention the ethical complexities of offering treatment versus placebo when there is a known standard of care like naltrexone and acamprosate plus behavioral health. I'm also surprised the IRB didn't flag this. I don't wish to be inflammatory when saying I know none of us would treat cancer with placebo when considering a new regimen. Yet somehow, societally, we are okay with this for addiction medicine, which highlights how widespread stigma is. And I think that's a great point, Dr. Barrett. We aren't sure why the IRB here allowed this study to proceed with a placebo arm rather than using one of the other standard of care treatments for comparison. But I haven't had time to yet, but I will email the authors of the study. And if they get back to me, I will let you know. What do you think, John? Do you think it would have been it was unethical to have a placebo arm in this study?
I don't know. I'd have to ponder that a little more. I certainly wouldn't call it unethical, like it's an unethical trial. I think it's hard with substance use. I mean, it's tough. The most common outcome for recovery in alcohol use disorder, I mean, this is a board question. It's non-abstinence recovery, right? So, like, I feel like that a lot of patients, the most common people that do recover actually don't do it with medications. It's just non-abstinent recovery. So they kind of like still drink, they still go on with their life. They're just not quite as sick as they once were. I don't know.
We had done another paper. I forget what episode now. I'd have to look through the archives, but it was about treating alcohol use disorder in the hospital. And we had wished there was a placebo arm, and there wasn't. And I actually thought it was this same issue. And I had asked the authors, was it unethical to have a placebo? Is that why you didn't do it? And they said no, because less than 2% of people actually receive treatment for alcohol use disorder. Doing nothing is actually standard of care, societally, even though we have treatments that work. Most people just get nothing. So people in the placebo arm aren't actually having a care withheld. They're just getting what everybody else gets.
I guess it depends what you call standard of care. Is it like ideal treatment or is it real world treatment?
What everybody actually gets.
I would say standard of care is actually like ideal treatment, at least what I would think of. Maybe that's an interesting question for the audience. What do you think of with standard of care? Is it ideal or is it real world?
Well, and I hate to even say this sort of officially because I don't want to be wrong, and I might be. So take this with a grain of salt. But like, there have been other trials where they've compared placebo to a known treatment, and the question about whether the placebo is ethical or not has come up. And if without the trial, if nobody would get the treatment, then it's not considered unethical in some settings to have there be a placebo. Or at least that's an argument that's been made in the past. I don't think actually that's current ethical standards, but like example, early trials of AZT for AIDS done in settings where nobody gets any treatment. So you come in and do a placebo arm plus a treatment arm. Is that ethical? Whereas if the study wasn't there at all, nobody would get any treatment. So the people who get placebo are just getting what they would have gotten anyway. That's kind of what we're saying. I don't want to say that that's ethical. I kind of agree with you. The ethical thing would be to give people the treatment that works. But
no. Don't ask these questions too much or else we're going to have to get reassigned a city ethics training by the IRB at our institution. I already had to sit through that for like 13 hours last year. I can't do it again.
I know, it's so long. All right. On that note, I'm riffing too much here. I'm like, I don't know. I'm going to stop talking now. Anyway, thank you everybody for listening to the Addiction Medicine Journal Club. The best part of any journal club is a conversation. We really want to hear what you have to say. We would love to get comments about the articles. So you can send us comments on social media, email, join our Facebook group. The links are all in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.
If you're looking for a down-to-earth podcast about how people change their life to reach their goals, go listen to the new series of Madly Moved with Maddie Mad Stirs the Pot. We talk about how mental health can make you feel paralyzed until you learn how to change through healing yourself daily to reach the you that you always dreamed of being.